Uh, when I started working in Chiwoko, we didn't have NICU facilities. Reason why the hospital was just being started and was being built up, and we had only maternity. And by then, the first maternity we had, the maternity had about 8 beds, and we were very few actually. Before that, before we had the NICU, we could nurse the babies together with their mothers. And the babies could not really cope up very well because they didn't have enough space, and we couldn't isolate babies from the moms so that they could get enough care, which they would have got like they should actually. First NICU, we are happy to have the first NICU because that was the first of its kind. The first NICU, we had 2 small rooms, which looked like a sitting room and a bedroom. So the first room, we could admit babies from our maternity here, the babies who had any problems during early neonatal age, like hypoglycemia, hypothermia. We had even the premature babies in that unit. And then the other room, we could nurse babies from the community and also isolate babies from the community. And as the first beginning, we didn't have many babies because nobody knew that we had that kind of ward in Chiwoko Hospital. But as we continued nursing the babies and the number grew up and people got to know more about the NICU ward in Chiwoko Hospital, they began bringing in their babies, and more babies came in from the community and other health facilities. So when these babies came in, we had the care to give them, and they began improving, and we saved many neonatals. The NICU of today, we moved in 2010 May. That was when it was opened, and it is more spacious, but also as time went on, within the 2 years, we began having many babies. We have enough equipment right now, which we didn't have in the first NICU because there was no space. We have enough oxygen concentrators, we have monitors, we have the IV infusion pumps, and we have the radiant warmers, and we have enough cots and enough incubators because that was what we actually needed. That was our dream, to have enough space so that we could have more babies.
Our quality of care is good, and the good thing, we are supported with ADARA, and we have all what we need. With other centers where we've been, people are like, you find 1 nurse per shift and there are many babies, but at least for us, we find 60 people on a shift, of which it is possible to help babies. Even if there are emergencies, there is teamwork. Now, like our NICU now, it is known with the good care we give. So they want to improve our newborn care around Uganda, and our NICU was chosen as a role model. So people come from different regions, and we've hosted people from the northern part. They are got from different centers, and they come in to run.
Based on ADARA's success working with Chiwoko and knowing there are many lives being needlessly lost across Uganda each year, we have developed a model that we could share with other facilities about the work that is going on in Chiwoko, and that can be used to help other facilities and the countries to save newborn lives. And this is ADARA Newborn. And our Adara newborn model addresses the complex factors facing mothers and their babies, addressing each point of care. From the time the mother becomes pregnant, throughout pregnancy and delivery time, caring for the infant and supporting high-risk infants after going home. So this model aims to reduce facility-based newborn deaths and stillbirths by 50%. In order to meet this goal, we need to address the quality and availability of services across the continuum of care. We will work across 5 arms of care: antenatal, intrapartum care. We have inpatient care for sick and small newborn, postpartum care for moms and babies, and follow-up care for higher risk babies in the community, linking them to the service when needed. So in each arm, we will focus interventions that will have the highest impact. Our experience at Kiwoko Hospital has shown us that introducing a training program or providing equipment alone is not enough to create a sustainable change. So what is our way forward? Through our Adara newborn theory of change, we have identified several factors that are critical to the success of this work. And these factors include sufficient number of sufficiently trained staff, evidence-based interventions and guidelines, physical resources including space, infrastructure, family-centered care, reduced barriers, monitoring and evaluation programs, finance support, and strong leadership and governance systems. All these factors contribute to the success of this work, and they are very critical in this work. So we have set ambitious goals to reach over 500,000 women and children and save thousands of newborn lives in Uganda over the next decade.
My spiritual brother come to see the babies. He's sick and the babies is not okay. He tell me, you go here, Kiwoko Hospital. We are going to, the sisters are going to help you. You the children come fine. I'm very happy for taking care of me, for my children, even for food, for porridge, everything okay. Me today I'm happy because my children is okay.